Welcome to this short video produced by Trauma Informed Oregon. You've likely heard conflicting thoughts and feelings on trauma-informed care in educational settings. This video is designed to briefly respond to some of the most common misunderstandings that arise among educators working with trauma-informed care. Misconception. Trauma-informed care is excusing or enabling undesirable behavior. Holding people accountable and punishing them are not the same thing. Understanding the why behind the behaviors, creating clear expectations and consequences, and supporting growth toward desirable outcomes is more ideal. So often, trauma-informed care is confused with lack of accountability. However, trauma-informed care is more about setting reasonable boundaries and logical consequences. By logical, we mean that the consequences are appropriate, relevant to the concern, and equitably enforced. This offers students a chance to take ownership of their growth and develop life skills. Checking in with a student doesn't mean letting them off the hook, but it can provide valuable information on appropriate next steps in supporting them toward meeting the desired expectations. Sometimes others may not see the consequences of a student's actions, and that can be construed as a lack of accountability, when in reality, there is an established plan, it's just not publicly obvious. Many of us experienced punishment for wrongdoing in school or at home, detention, copying lines, etc. However, logical consequences can build relationships and positively support students toward meaningful growth. Misconception. Trauma-informed care is nonsense, and students with trauma just need to be disciplined or have some limits set for them. One of the most effective ways to engage a student is to build healthy relationships and connections. Compliance is not engagement. Boundaries are healthy, and students certainly need clear and defined limits. However, that doesn't mean executing punitive measures as a way of deterring students from undesirable behaviors. We use punitive here to denote punishments doled out as a means of enforcing power differentials, tearing students down rather than building them up, and/or consequences that are transactional rather than relational. Instead, helping students learn how to establish and maintain boundaries and limits builds community and sets them up for success. There can be predictability and consistency in this practice without being punitive. Misconception. Trauma is private business. Schools should not be the parents. While trauma may happen outside of school, the effects often manifest in school. School may also be the source of the trauma. While many of the things that affect our students' lives happen outside of our spaces, they bring those experiences with them wherever they are. It may not be intentional, but their reactions to stimuli are deeply affected by their prior experiences, whether they happen in school or not. The same is true for adults. When something terrible happens outside of work, it may make it difficult to navigate scenarios that are normally easy. Though our minds may want to leave home at home, sometimes, even despite our best efforts, emotions manifest at school. Misconception. Children who carry trauma lack resilience or grit and just need to learn to develop it. Resilience does not equal toughness. Trauma survivors can often develop coping mechanisms that can be profound strengths and skills. While some trauma survivors may develop grit or toughness, there is value in softness too. Developing compassion for others might be another consequence of experiencing trauma, and it is neither better nor worse than developing grit. When we recognize our students' unique skill sets, we can create thriving learning communities where everyone is seen, valued, and heard for who they are. Misconception. The designation trauma should only be for catastrophic things. Trauma-informed care is widening the definition too much. Our definition has evolved over time and helps us understand why and how people can react differently to similar stimuli. Languages evolve, particularly as we learn and innovate. Trauma is a word that has continued to evolve as more is learned about the ways in which the brain and body process and respond to stimuli. An event that may seem small to one person may have a drastic impact on someone else based on prior experience and associations, consciously or not. Trauma is defined in the dictionary as a deeply distressing or disturbing experience. There is no universal objective truth. We all process things from our own lenses. Where one student may relish being called to the front of the room, another may shrink from that kind of attention. Consider a student who had the event of being laughed at for struggling with reading early on. If left unaddressed, they may experience shame or humiliation and be hesitant to read in front of others in the future. And perhaps the effect manifests as anxiety or anger or any host of other emotions. This response may lead them to have explosive behaviors to avoid it, or to mentally check out, or even skip class or school altogether. However, if there are supports in place that can intervene, that student can build up the skills to overcome those responses and learn skills to help them be successful moving forward. Experiences are deeply personal, but appropriate support can offer buffers to help students process and move through challenging ones. Misconception. Trauma-informed care is only about adverse childhood experiences, or ACEs. Trauma-informed care is a systemic approach, and though there are technical pieces like ACEs, that is not the entirety. Adverse childhood experiences, or ACEs, are one of the most common associations people make with trauma-informed care because they are technical, concrete, and identifiable things. However, while they certainly play a role, they are only one part of the larger adaptive practice of trauma-informed care. ACEs help provide the shift of recognizing that it isn't what's wrong with students, but what has happened to them. We've moved further ahead and understand that what matters most is how our students show up in front of us in the here and now. We don't need to know their trauma histories to support them. In fact, if we get tunnel vision and focus on an ACE, like knowing a student's parents divorced or that someone close to them died, rather than taking in the whole child we are supporting, we may miss other relevant information. Misconception. Trauma-informed care is only for kids with major behavior problems that need therapeutic interventions. It is about diagnosing and putting kids into special education and is only applicable to therapists or counselors. Trauma-informed care encompasses many strategies, many of which you're already doing, some of which may be therapeutic and supports everyone toward meaningful systems change. Educators are already doing so many of the interventions that trauma-informed care practices would suggest. Standing at the door and welcoming students in, having a quick check-in with a student who seems off that day, setting clear expectations and norms in your space, all of these are trauma-informed practices. While many of trauma-informed care's interventions are therapeutic in nature, there is significant overlap with interventions in the academic setting. Everyone has a role to play in the application of trauma-informed care in a school, from facilities to front office to coaches and administrators. We each contribute to a trauma-informed environment for our students and each other. Misconception. Trauma-informed care is politically motivated with a liberal agenda. Having trauma-informed settings benefits everyone, regardless of their political beliefs. Many trauma-informed care initiatives have strong bipartisan support. Trauma-informed care has no political affiliation, and the practices benefit not only students, but everyone within the system. While aspects and policies promoted by trauma-informed care are political, like access to fair and equal housing, education, etc., many of these issues have bipartisan support. Trauma-informed care works to center lived experiences, address historical disparities, and intervene to prevent future oppressive practices. Misconception. Trauma-informed care is about implementing a curriculum and giving students who have experienced trauma special tools. Providing or altering a curriculum is a technical solution to an adaptive problem, and trauma-informed care addresses both technical and adaptive aspects. Implementing trauma-informed care requires comprehensive reimagining of schools top to bottom based on what we've learned about trauma in the last few decades. Like ACEs, curriculum and toolboxes are one aspect of a trauma-informed care system, but they are not the entirety. The how matters more than the what. Trauma-informed care is a systemic approach to supporting not only students, but staff and the community at large. Thus, we need to look beyond the strategies toward policies and procedures that support these strategies toward systems change. Misconception: trauma-informed care is just about training staff. Training staff is important, but ideally only one piece of a larger process. Trauma-informed care is not just about information, it's about the integration and systems change. While training is a critical component of developing trauma-informed spaces, without coaching, mentoring, and ongoing consideration, training can fall by the wayside. Trauma-informed care is an iterative process of trying, evaluating, and trying again. Through the 4 R's, schools can move through the process of continuous improvement while centering the lived experiences of our students. Thank you so much for your time and attention.